Welcome to Surgery or Biologic for Nasal Polyps, a close look at the evidence, presented by the Global Education Group in collaboration with the Asthma and Allergy Foundation of America, broadcast on immunologylive.com and resinsightslive.com. My name is Dr. Stella Lee. I'm the Section Chief of Rhinology at Brigham and Women's Hospital at Harvard Medical School. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Cohen, Professor of Otorhinolaryngology, Head and Neck Surgery, and Director of Rhinology Research at the Perelman School of Medicine at the University of Pennsylvania. Thank you, Noam, for joining me today. Let's get started. These are our disclosures. And I'd like to go over the learning objectives. We'd first like to describe the inflammatory relationships between nasal polyps and common T2-driven comorbidities, discuss safety, efficacy, and impacts on bothersome symptoms of current targeted therapies for patients with moderate to severe CRS with nasal polyps, and then review patient-specific factors that help predict nasal polyp recurrence after standard treatment, including surgery. So I'll now pass this along to Dr. Cohen, to Noam, to talk about uncontrolled severe nasal polyps. What are they?
Okay. Well, thank you, Stella. Again, as an introduction, I'm Noam Cohen. I'm at the University of Pennsylvania as a rhinologist, and I spend a lot of my time actually doing research on nasal polyps. So let's get started with what are they. So this is a severe form of nasal polyps on the left side. This patient actually had something called Wilkes syndrome, where the polyps were so severe that he had telecanthus. The eyes were actually pulling apart and got wider because of the polyp burden. The middle picture is a more discrete polyp that we're only picking up if we put an endoscope in the nose. And on the far right of the screen, you can see the polyp burden that we could potentially harvest out of patients with nasal polyps. So these are non-cancerous polyps, unlike the polyps that we talk about in the gut. They look like skinless grapes, basically filling up the entire nasal cavity. The presence of polyps tends to go along with a syndrome called chronic rhinosinusitis. And there are many different flavors of chronic rhinosinusitis, but basically it is an inflammatory disorder of the nose and paranasal sinuses that is characterized by at least two of the cardinal symptoms that are listed below: nasal blockage, discharge, pain and pressure, or reduction in smell. And those symptoms have to persist for at least 3 months. So sinusitis really comes in two different main characterizations or phenotypes. There's chronic sinusitis without nasal polyps, which is the top row. And when you look in endoscopically inside of a nose, it's usually an infectious process. So you'll see purulent secretions draining out of the sinuses. On CT scans, you'll often see thickened bone and air fluid levels consistent with infection. And the inflammatory cascade that is associated with chronic sinusitis without nasal polyps is more of a neutrophilic or Th1-driven inflammation. The bottom row are the characteristic signs and findings of chronic rhinosinusitis with nasal polyps. So as I mentioned before, they look like these skinless grapes filling up the whole nasal cavity, and you can see that on the endoscopy. Radiographically, you typically get a complete whiteout or complete opacification of the paranasal sinuses. And from an inflammatory standpoint, this is more of an eosinophilic-driven disease. And these are the classic historic ways that we always thought about chronic sinusitis with or without nasal polyps. The second one, chronic sinusitis with nasal polyps, is really reactive airway disease. And it's a continuum with asthma. A matter of fact, asthma is present in 20% of the patients with chronic sinusitis, and between 20 and 60%, and 7% of patients with asthma have nasal polyps. Many of my more difficult patients get referred from pulmonary because we know that if we can get the polyps in the nose under control, the asthma is actually better, more easily managed. And then we also think about nasal polyps in a genetic disorder called cystic fibrosis, but ironically, the polyps in CF are not eosinophilic, they are neutrophilic. So while they present as polyps, it's a completely different inflammatory cascade. Now, the signs and symptoms that go along with these two different subtypes of chronic sinusitis are slightly different. Non-polypoid chronic sinusitis is often presenting with pain and pressure, really thick nasal discharge, and obstruction. Whereas patients with polyps, even though they can't pass any air through their nose, they very rarely complain about nasal obstruction. Their primary complaint is hyposmia or anosmia, along with their asthma symptoms. So they rarely present with pain, but it's mostly just with, I can't smell and I can't taste my food. Now, as we've learned more about this spectrum of inflammation in the nose, we started realizing that there are different inflammatory cascades that contribute to this syndrome. So as I mentioned, there's the type 1, which goes along with the infectious process, the type 2 that goes along with the nasal polyps, and the type 3, which is kind of a blend. And as I put down on the bottom of the slide, that in type 2, 85% of severe patients with polyps also have lower airway inflammation manifesting as asthma. As we started doing more and more endotyping, we started realizing that it's not all Th1 or all Th2, that it's really blended. And this is from a large study out of Northwestern that basically looked at biomarkers at all these different inflammatory cascades. And you can see that in nasal polyps, there still is a significant contribution of T2 cytokines. And even in nasal polyps, there's a little bit of T1. So it's not all Th2 or all Th1, it's really blended. The comorbidities that go along with this disease, as I mentioned before with nasal polyps, are asthma and allergic rhinitis, but we can also see polyps in different forms of infection, as I mentioned, with cystic fibrosis. There is a severe form of nasal polyps that goes along with aspirin insensitivity or aspirin intolerance called AARD. And we'll also see polyps if there's severe anatomic obstructions. So the impact of sinusitis and asthma, they go together. And as I mentioned, many of the patients that get referred to me from pulmonary are not really because they're having problems with their nose. It's because the pulmonologists are having problems managing the asthma. And studies that were done back in the late 80s and early 90s demonstrate that if you get good control of nasal polyps, you can actually get better control of the asthma. So as the polyps get worse, asthma symptoms get worse, the asthma control gets worse, the obstruction in the lower airways gets worse. And we see the same thing. When the asthma flares up, the polyps come back. So it's all this unified airway concept that it's inflammation throughout the respiratory epithelium that is driving this edematous component of inflammation, this eosinophilic inflammation. So I mentioned to you that we can, the endoscope, I want to talk about how we actually diagnose it. So in the primary care setting, we can use anterior rhinoscopy, just a simple nasal speculum. And if the polyp burden is large enough, you can basically see them just inside the nasal vestibule. You can see large grape-like structures filling up the whole nasal cavity, as you can see here. And this is usually what is done in primary care or in the non-ENT specialties. But as an otolaryngologist, we like to use the endoscope, which allows us to really map out the entire nasal cavity. And so this was introduced into ENT back in the 1970s by Walter Messerklinger, who was playing around with improving diagnosis of rhinologic disorders, and demonstrated that you can get, with a rigid endoscope or even a flexible endoscope, great optics within the nose. And so when we use an endoscope, we tend to characterize our polyps based on how big they are. And oftentimes, the source of the polyp is usually out of the middle meatus or out of the ethmoid. So it's basically hanging down from the roof of the nose. No polyps gets a score of 0. If you have polyps that are coming down to the level of the middle turbinate, they're graded as a grade 1. Below the level of the middle turbinate is a grade 2. Down to the inferior turbinate, but leaving the floor preserved, is a grade 3. And if they get all the way down to the floor and fill up the entire nasal cavity, it's a grade 4 polyp. And so we use these nasal polyp scores to assess or to basically record the polyp burden that our patients are suffering from. In addition to nasal endoscopy, we can use radiology. And the modality of choice, at least for the paranasal sinuses as a first-line imaging, is non-contrast CT scans. And so what we're looking for is a normal sinus should be filled up with air, and you should see a very, very sharp transition from the bone to the lumen. So basically a very sharp transition from the white to the black. Any gray lining those sinuses would suggest that there's some form of inflammation. And if there's complete opacification, then that means that the sinus is completely filled up. That is usually 90–95% of the time all that you need to do with regard to imaging. And it's not necessarily necessary to start the process. We usually use CT scan if the initial intervention that I'll talk about just down the road is unsuccessful, and we try to figure out a little bit more about how much the polyp burden is that we can't observe by endoscopy. In rare instances, if there's something atypical about the opacification, if it's unilateral, if it's only involving one sinus, if it looks like there's bony destruction and we're concerned about other pathologies such as tumors or allergic fungal sinusitis, we can get an MRI, but that is rare. Most of the time, you can make the diagnosis of what you need and to plan out the therapy based on a CT scan. So we're going to pause here. Oh, I'm sorry. So we're going to go on now to how we manage sinusitis. So we are going to go to an audience polling question, which is, how confident are you in your ability to effectively manage uncontrolled severe nasal polyps? A, not at all confident. B, not very confident. C, confident. D, very confident. E, extremely confident. And the poll is split between A and B. So clearly we're not doing a very, very good job in taking care of our patients because they're not very confident in our ability to control, or in their ability to control nasal polyps. So in a patient-related program, the question was asking, how satisfied are you, this is to the patient, of the person who is caring for you for your nasal polyps? 3% were not satisfied at all. 1/3 were not very satisfied. 46% were satisfied, and 16% were extremely satisfied. So about a 50-50 split between being satisfied and not being satisfied. So the principles of managing nasal polyps is to reduce symptom severity and to decrease the burden. And there are really no specific guidelines that address the biomarker driven, as I said, and that's where we're going, is to try to identify biomarkers to improve our therapy. But the goals are to reduce the polyp size, to relieve those symptoms of either anosmia, nasal obstruction, the facial pressure, improve the quality of life, and to really prevent recurrence. This is from the expert guidelines from 2021, where we basically started with, we look at the cardinal symptoms that we talked about, anterior rhinoscopy, you make the diagnosis, and the first intervention really is just topical nasal steroids plus or minus nasal lavage. And you do that for about 4 to 6 weeks, and you reassess the symptoms. In some patients, that is all you need to do. Get a little bit of an anti-inflammatory in the nose, the polyps will regress, the symptoms will regress. But in most patients, it persists. And then we start talking about additional things to do. Allergy workup, aspirin desensitization, if there's an aspirin intolerance, looking at some of the zebras. Is there any other kind of rheumatologic disorders that could be contributing to the nasal polyps? And then there's some new, really innovative ways to deliver medications into the nose. And I'll talk about the exhalational delivery system in a couple slides, but it basically leverages retrograde flow into the nose to try to improve delivery of the anti-inflammatories. As I said, the majority of patients need a little bit more than steroids. Those that still have persistent symptoms, despite either oral steroids or topical steroids, that's when we start discussing surgery. And I'll talk towards the end of my section about what the surgery involves. But even when we do the surgery, it is not to replace topical steroids. Steroids is basically the mainstay of the therapy. The surgery basically will allow for reducing the polyp burden and making the sinuses more amenable to topical therapy. The surgery is about 85% successful. But even in the patients that have surgery, as I said, 15% do still have persistent signs and symptoms. And then we talk about escalating it up into either the monoclonal biologics. Is there any surgical errors that were done that will require revision surgery, aspirin desensitization? We can also do sinus implants both in the operating room and in the clinic, and I'll show that in a little bit, about how we can get high-dose steroids in the nose for about 4 to 6 weeks. So as I said, the cornerstone of the therapy is topical steroids. So nasal sprays, there's this exhalational delivery system that basically delivers the steroids retrograde. And then the real workhorse is high volume irrigations. And this is the sinus rinse bottle or the neti pot or the Navage that basically really flushes out the nose with about 1/4 liter of saline with or without steroids. A matter of fact, this is the one that I use predominantly, which is a budesonide nasal irrigation on my patients for even pre-op is what I do. And again, the goal here is to reduce the polyp size and to see if patients have not had surgery, if this could potentially avoid surgery. From a long-term effects, the topical steroids and the steroid irrigations have been demonstrated to be excessively or exceedingly safe with very little systemic absorption. So this is the exhalational delivery system, an absolutely ingenious device. And what it basically entails is you blowing into the applicator. So one part of it goes into your nose, one part of it goes into your nose, one part of it goes into your mouth. And when you blow out of your mouth, you close the soft palate, which basically seals off the nasal cavity. As you force the steroids down one nostril, they get to the back of the nose, to the nasopharynx. And because the soft palate is closed, they can't get into the oropharynx. So they're forced to basically make a U-turn around the choana. And this is where the therapy happens, is because the delivery is coming from the back of the nose forward. If you think about the anatomy of the sinuses, everything is built to protect against things getting into the sinuses. So the uncinate process deflects things down, and posteriorly, everything basically is pushing, as you breathe into the nose, it's pushing it towards the nasopharynx. So if you want to deliver things into the sinuses, if you can drive it in reverse, basically deliver it from the back of the nose forward, the anatomy is in your favor and will push your medications into the sinuses, into the frontal recess, into the maxillary sinus. So retrograde flow is really the therapy here. And so that's why this exhalational delivery system is so effective, is because it's that retrograde flow through the contralateral nostril that's delivering the steroid. So the goals of surgery is, again, to basically improve patient symptoms by debulking the inflammatory processes in the nose, which is goal A. But goal B is really to make the sinus mucosa more accessible to our topical therapies, be it by spray or be it by lavage. And so really the idea, the way that we do our surgery now is really it's an access surgery so that we can get our topical medications inside the nose. So what I have here is on the left is a schematic of the craniofacial skeleton going through unoperated, okay? And what you can see is the uncinate process, the maxillary sinus in the bottom left, which is very narrowed by the hiatus luminaris, which is the way that the sinuses flow out. The ethmoids, it's basically this lattice of bony structures that make the outflow very, very narrow. The surgery is really a marsupialization surgery, where we remove all these small bony partitions within the sinus cavity, avoiding getting out of our real estate, meaning we don't poke into the eye and we don't go north into the brain. And we basically make a large common cavity. So even if the lining of the sinuses gets inflamed and it swells up, it does not obstruct the flow of mucus. And so on a CT scan, if we look at a sagittal, you can see all those little bony partitions that make up the ethmoid cavity and the sphenoid, and I've basically listed them on the left. The idea behind the surgery is to basically remove all those little bony partitions and create a large common cavity. Now, the toughest part of the surgery is the frontal recess, which is the narrowest point. It's like an hourglass. And in this image, it's actually quite wide, but in many of our patients, it's very, very narrow. And so we have additional surgical approaches to make the frontal recess wider. And they're named after Wolfgang Draft, that he was the first one to describe them. So Draft 2A removes all the bony partitions with mucosal preservation. 2B takes down the root of the middle turbinate and allows you to expand it all the way over to the septum. So you're basically doubling the width of the outflow tract for the sinus. And a Draft B and a Draft 3 combines the right and the left. So it goes across the midline. It takes out the superior part of the nasal septum and combines the right and left frontal sinus outflow into a common cavity, which makes it a lot larger. But if there's a lot of inflammation, it allows the sinus to stay open. So as I said, surgery really is an adjunct to medical therapy. And the way that we're thinking about it now is not about ventilation, but it's about access, making it as big as possible, the holes as big as possible, so that when you flow in your steroids or your antibiotics and your irrigations, they will be able to get into the sinuses. So in addition to anti-inflammatory steroids, we also use anti-leukotrienes. Again, allergy management is critical, aspirin desensitization, and the question of biologics is coming up. And that's where Stella is going to take over. But I just want to talk about successful and unsuccessful surgery. So this is the ideal post-surgical cavity, wide open on both sides. And you can see there's very, very little inflammation. This patient is excessively happy that they had their surgery. This is a patient where you can see that there's persistent mucosal edema, but overall the patient is doing okay, kind of petering along. They'll flare up, they'll get a little bit better, they'll flare up. And this cavity is very easily managed with additional medications a couple times a year or increasing dosing in the irrigations. And this is a patient who basically had the exact same surgery that is profoundly symptomatic, and something additional to the surgery needs to be done. Now, I mentioned earlier on that we do have some adjuncts to the surgery, and I just want to talk about some drug-eluting stents. So there are a couple companies out there that make these stents. These are basically biodegradable stents that have been impregnated with steroid. This is the mini, this is the contour, and they basically are designed to go into different parts of the cavity. The mini goes into the frontal recess and is basically positioned here at the end of surgery. The contour goes basically into the ethmoid cavity. And so here you can see this is with a 45-degree scope looking up into the frontal recess and into the frontal sinus. And as I said, it's like an hourglass. This is that stent in position at the time of surgery, at the end of the case, being positioned into the frontal recess. And this is basically looking into the ethmoid cavity. Sphenoid is right here with the stent right there. And these will stay in place after surgery for about 4 to 6 weeks, eluting steroid into that area and helping to reduce the inflammatory burden in the post-op period. So as I said, we're about 85% successful, but 15% of patients have persistent symptoms despite having surgery. And this is usually because the polyps are recurring, as you can see here on the first image, incomplete surgery with osteoneogenesis and osteitis in the middle figure, and or persistent infection in the form of biofilms that are very, very difficult to eradicate. So that's where we have been and over really up to the last 5 years. And I'm going to pass it off now to Stella to start talking about what the real future is for regard to post-surgical or very persistent polyps that are not being managed appropriately with the current medications.
Thanks, Noam, for that great introduction and overview. I'm going to switch gears a little bit and talk about recurrence for the unhappy patients, unfortunately, but now we have some other therapeutics that can be quite effective. So I'll talk about that later in this part of the presentation. Let's look at this chart. It's really a great representation of patients who have, for example, patients without asthma are on the top black line, patients who have asthma are the middle line, and the patients who have aspirin exacerbated respiratory disease on the bottom line. It's a Kaplan-Meier curve, but it shows you the recurrence rate after the surgery, whether the patient had had recurrence or not. And you can see that patients with aspirin tolerant asthma, or just basically they don't have AERD, but they have comorbid asthma, they have 1.7 times higher risk of recurrence versus patients without asthma. And then when you take it one step further, patients who have AERD have 3 times higher risk of recurrence versus patients without asthma. So the comorbidities are really important to consider. This is another interesting study that looked at recurrence rates also after surgery. And I wanted to point you to the post 18 months. Total is the black. And then we see polyp and edema. But in general, the studies show that patients, approximately 40% had recurrence of polyps at 18 months. That does not mean that those patients were symptomatic, but it is important to realize that polyps, unfortunately, do have a high rate of recurrence. And I think all surgeons think that they are the best surgeons, and we all do the best surgery possible for our patients. But unfortunately, despite our best efforts, some patients do worse than others, and it might be related to comorbidities, as we discussed. This is another slide that talks to that point, that the median time to recurrence, if you go down the column, that patients with AERD, or what they call in Europe NERD, in the US we call it AERD, you have a shorter time to recurrence as you go down the column, as you can see, and then a median time to revision surgery as well. So this is an important risk factor, and also really critical when you're considering not all patients with polyps are created alike. So as Noah mentioned, endotype-specific management, it would be great if we had a biomarker that could tell us which patient would be a great candidate for this kind of surgery or this kind of topical therapy regimen post-op, but we don't have that yet. And we are still trying to determine that. But I think understanding the patient, including considering the comorbid conditions, is really critical. We do know that the ARD subtype, those patients do have the most severe disease, the highest dependence on oral corticosteroids, the highest radiographic severity. And then when we look at polyps, if you have the ability to look at that in a structural histopathologic way, it's a great way to potentially look at specific inflammatory mediators, such as eosinophils per high power field. And if we could get a standardized way to do this across the board, that'd be wonderful, to look at potentially IgE levels and IL-5 levels, et cetera, et cetera. But that's the future. So briefly touching back on the endotypes, we have to know this language because it's so important now to understand which patients might fall into what particular inflammatory subtype. And as you can see on the top, we still have patients who are untypable. But as you can see here, there's T1, T2, T3, the different cytokines that are characteristic for those types of inflammatory subtypes, the cells that are involved, the effector cells that are involved, and the targets. And there's a reason why we have these types of immunity in our body, right? And then you can see the types of specific clinical features. Typically with T1, 2, you do see purulence as well as with T3. Type 3 inflammation. And so wanted to go to a polling. We wanted to talk about the safety and efficacy of biologics for nasal polyps, but starting with this audience polling question, what percentage of your patients with severe uncontrolled nasal polyps would you say you have discussed biologics as a possible treatment? A, 0%, B, 1 to 25, C, 26 to 50%, D, 51 to 75, or E, 76 to 100%.
So Stella, where are you using biologics in your clinic right now?
It depends on the patient. If a patient has AERD, if a patient has had multiple surgeries, and then I have an honest discussion. If, for example, there's a patient who does not have asthma, but just has polyps and severe polyps, and they've never had surgery, I think, it behooves me to definitely have a conversation that these biologics are available. But someone like that, I would say probably would best have a good outcome with surgery alone first, and have a really good first surgery or only surgery, if ideally. But yes, what about you?
I'm starting to use it a little bit more in the elderly that are just not good surgical candidates, that anesthesia is not going to let me do it. So I'm leaning more that way. But again, I'm using it as a fallback on the patients that do not do well with surgery with post-op steroid irrigations. And it's not that many, but those are the ones that I'm actually finding, it's the only thing that seems to be working in those patients. The question is do I start bringing it up a little bit further up in my management? I don't know if I'm ready to pull the trigger to say biologic before surgery, with the exception if they're contraindications to surgery.
Yes, great points. So the audience members, thank you for participating. The most common answer is B, 1 to 25%. So, it's interesting with this next study that was done. It was polling the platform Q data, and they asked, were you aware that biologics are available to treat nasal polyps? And it was almost 50-50. So it's interesting that we still, some folks are still getting this information now. But it was only since 2019 that dupilumab was approved. So there's a lot of information, education, and research that we still need to do. So briefly going over the biologics for CRS, the ones that have been approved are omalizumab, dupilumab, and mepolizumab. And I know this is a quite busy slide, but I wanted to point to the top of the slide where the epithelium there's a breach there, but there is a lot of interesting information and research done on the barrier, but potentially other etiologies of CRS. We still don't quite have a handle on potentially the triggers and the mechanisms, although we are getting there, especially with Dr. Cohen's amazing research. But there are potentially environmental factors that could be at play, as well as patient factors that then lead to a dysfunctional type 2 process, and also potentially a mixed process, as Noah mentioned too. So DUPI blocks IL-4 receptor alpha, also which leads to blockade of IL-13. Mepolizumab blocks free IL-5, and omalizumab blocks free IgE. So you can see benralizumab here on this slide that's blocking IL-5 receptor alpha. We had very high hopes, and we still potentially might see some benefit, but this drug was not approved for CRS with NP after the phase 3 trial. And this is a summary of what I just said, that these are the 3 biologics currently approved. And as you can tell, they all target different things, and they all have different dosing and different protocols. So it's important to realize that some patients don't realize you do have to inject yourself every 2 weeks, and some patients may only need to do it once a month. So those are some differences. Wanted to go over some of the key clinical trials that led to the approvals of these medications. I think all of us should know about these. Sinus 2452, or the Liberty study, looked at dupilumab in severe CRS with NP patients. And as you can see on the left-hand side, we looked at both an objective measure, such as a nasal polyp score, as Noah mentioned, as well as a symptom score. And both also, so the blue is treatment with DUPI, and the upper line is placebo. And as you can see with the 24, which means 24 weeks versus 52, that dupilumab treatment translated to about a 2-point decrease in nasal polyp score, and about a 1.4-ish decrease in nasal congestion score. So that was significantly different than placebo. And interestingly, too, when you looked at how many of these patients did not have to go on to like a steroid course, like systemic steroid therapy, rescue, or nasal polyp surgery, and there was about an 85% reduction. This is an interesting study that we did at University of Pittsburgh. My resident was the one who had the idea of comparing dupilumab versus sinus surgery. And these patients, there were about 50 patients in each group. They were case matched based on nasal polyp score and SNOT 22 and all those things. And when you looked at the differences between surgery versus DUPI, surgery won out at the nasal polyp score, which makes sense, as Dr. Cohen mentioned. With surgery, we're removing all the polyps, hopefully. But with the olfaction domain and the extranasal rhinologic domain in the SNOT 22, so unfortunately, it would have been a great study if we had actually upsit scores or more objective data. But based on the SNOT 22, it seemed that DUPI did win out for olfaction and for like postnasal drainage symptoms and cough. So going on to omalizumab, the important study that you need to know about is Polyp 1 and Polyp 2. These were replicate studies, and you can see the treatment line is on the bottom with the replicate and the placebos on the top. And the left-hand side is the nasal polyp score, the objective measure, versus they did a little bit a different analysis, but also with nasal congestion score, they also found about a 1-point change in nasal polyp score for. So 1.08, you can see 0.89, and then for nasal congestion score, about a 1.7 decrease in nasal congestion score. And nasal congestion score goes from 0 to 3, with 3 being the most congested. And there was an open label extension, which means that patients who did not get treated had the option to get treated. So you can see they were not treated at the beginning in the nasal polyp score, and then once they were treated, their polyp score did go down. And then when you're off treatment, for any once the biologics are discontinued, the polyps and the symptoms do come back. Omalizumab also showed improvement in SNOT 22, and if you look at the subdomains, also significant improvement versus placebo. So let's talk about mepolizumab next, which blocks IL-5. This was an old study that was done out in Belgium, and really interesting because they used IV mepolizumab in a pretty high dose of 750 milligrams. So that's higher than what's given now in our subcutaneous injections. But they did find a significant improvement in the mepolizumab group compared to the placebo group. And they did end up publishing another study that showed that intranasal IL-5 also could potentially predict which patients could be a responder versus a non-responder. The big study was the SYNAPSE study, which was the phase 3 trial that looked at the efficacy of mepolizumab, and there was a significant improvement in nasal polyp score, about a 0.73 difference, and they also looked at for nasal obstruction. It was a visual analog scale, so it wasn't an NCS, as I mentioned for the other two, but a visual analog scale. And they did show a 57% reduction in need time to first nasal surgery. Interesting thing with this study is that for enrollment of this study, all patients had to have one surgery before they were eligible to enroll. And this also shows that another study that was done about 105 patients, but they used the 750 milligrams IV, and they found that patients had a significant improvement in all of these outcome measures. Interesting here that they had about a 2-point decrease. So that's kind of interesting based on dosing. All of these biologics have been found to be very well tolerated and overall safe. I'm going to skip over this slide because there's another better slide for this. This is a great study. I think Dr. Cohen was one of the authors. Dr. Borish led the team, and you can see comparing all the trials, as I just mentioned, Sinus 2452, Polyp 1, Polyp 2, Synapse. Austria was the benralizumab trial. It's a little bit different, all the populations of patients. When you look at the comorbid asthma, the AERD, the systemic corticosteroid use, wow, if you look at this green one, it's pretty low, which is the omalizumab trials compared to the others, but they were all slightly a little bit different, which is interesting. This is a great study because right now we don't have head-to-head data. So they did a very complex statistical analysis of indirect treatment comparisons of all the biologic therapies, and they included aspirin desensitization. And green means the most beneficial, and red was potentially harmful. So as you can see here, it seems that Dupi, OMA, MEPO, even Benra in some cases potentially are very beneficial. It just seems like Dupi kind of had the better outcome for patient-reported outcomes and surrogate outcomes. But it is so tempting to compare all these, but they are, as I mentioned, they are all doing different things. And some patients may be better candidates for one biologic versus another, or perhaps surgery only and surgery and biologics, as Noah mentioned. And there are multiple consensus statements out there. The NIH is very interested in also developing guidance and helping us figure out where we should go. But right now, we still don't have a great biomarker. We really do need to incorporate patient preferences. And I know we all talk about shared decision-making, but it really is important to discuss with the patient what their preferences are. And this is a recent publication just this year that talks about some of the criteria. This is the Euphoria EPOS European consensus for biologic treatment, and we look at the criteria. Makes sense. I mean, they're not incredibly controversial. That you have to have type 2 inflammation, you might have needed systemic corticosteroids, you responded to them, you have significant impairment of quality of life, loss of smell, comorbidities. And the one difference that this is from the other consensus statements that the eosinophils did drop, they did decrease it to about 150 absolute count, whereas before it was about 250. So a lot of different consensus statements out there and guidelines that are, but we still do need further research to figure out where we need to go. So I'm going to go now, take it over to the Q&A. All right, so there's some interesting questions coming through, and I think the Q&A is the most fun part of all of this. So, all right, so maybe I can ask a question to Dr. Cohen. Which patients with nasal polyps or CRS with nasal polyps are good candidates for biologics, do you think?
Well, as I said, for me, it's the patients that I can't seem to improve with the standard of care that we went through. So patients that have persistent signs and symptoms, the patients that I'm using too much oral steroids on, I've already done all the surgery that I possibly can do. That's where I'm going to go to the biologics. I'm starting to relax that and starting to entertain it in patients that are simply not good surgical candidates, because I'm thinking about the long term, and we don't have decades worth of data on this. We have about 5 years at most, but we really don't know what happens if we completely eliminate eosinophils from our body. Granted, in the United States, we don't have a lot of worm infestations. It shouldn't be a problem. Maybe we'll start seeing this as these medications expand out into the third world, and we'll start realizing that there are some issues depending on the hygiene. But again, in a 30-year-old, I'm going to basically be as aggressive as I can from a surgical standpoint, but I'm starting to start thinking more and more about in the elderly patients, maybe biologic really is the frontline therapy, especially since they're not going to do as well if there is a surgical complication. And so the efficacy is really starting to impress me that this is a true viable option, potentially instead of surgery.
I also think, patients who want to start a family or women who want to get pregnant, they need to come off the biologic. I know there's some data on omalizumab, but we do need more data on that, because we're talking, this is an adult onset disease, and we have patients who are in their 20s and 30s potentially, who are younger, as I agree, so those patients, in my experience, they would rather, actually, the conversation, I do have that conversation. Some patients may not want to have kids. So yeah, most patients have wanted to try surgery first, but it depends, on what they've been through already, if they've had surgery already and didn't work for them. So completely agree. All right, some other questions. Do you have any markers or other specific patient characteristics that can help predict likelihood of more aggressive or likely to recur nasal polyps?
Well, so clearly asthma, and the AERD patients are the toughest ones, right? So if they've got aspirin intolerance, but that's more of a clinical phenotype, not necessarily a biomarker. We, as I said, people have done a lot of biomarker studies, and the data is all over the place. And one of the reasons why the data is all over the place is because as a community, as a scientific community, we really haven't come up with a standard of how we actually process this mucus. People are using sponges, people are using aspirators. It really is all over the place. To me, I think that it really is the bad asthmatics that are the most difficult to manage. Stella, you have any other thoughts?
I think the patients who have this mixed inflammatory endotype are some of the most difficult. I have AERD patients who have tried every biologic, because I work closely with Tanya Laidlaw and Katie Buca, and you work with John Boss, so I know. And so we see the worst of the worst, and it seems like nothing works. But it's interesting. I'm curious to know your thoughts too. There was some recent data presented at our national meeting just a couple of weeks ago about like when you would start a biologic and how it impacted like IL-13 mRNA. So is there maybe a potential for disease modification if you do biologic therapy like right after surgery, or like it was different based on patients who were on biologics way before they even had the procedure. So there might be some way of maybe eliminating that mucosal memory that's there, and then reset the sinuses. Do you think that's possible?
The issue that I'm running into is we know that as soon as you stop the biologics, the disease comes back. So if it's truly remodeling the whole inflammatory cascade, you would expect that you could start spreading out your injections, right? So if you're doing dupilumab every 2 weeks, maybe a year after that, and I've played around with this, and let's go to Q3 weeks or Q4 weeks, we know that as soon as the half-life of that antibody is done, if you have that lag, the disease comes back. So I'm not convinced that you're really remodeling the whole process. You're just basically cutting off the supply of what's driving the inflammation. The other thing that I'll say is that we think so much about the eosinophil driving this disease, but there are studies demonstrating that in certain drugs that basically remove the eosinophil from the polyps are still there. So I think the eosinophil is actually a late comer to the process and is not really driving the disease, but more of a bystander that we've used histopathologically as a marker, but is not really a key player in the pathophysiology of polyps.
Yes, we were definitely involved in that study where we, with dexpramipexole, where we eliminated all the polyps, and it was an orally available medication. And but the story that's not told is that we had one patient respond. So I know the paper was published and we published that it didn't work. We actually had a really hard time publishing that paper too, because it was a negative study. But I think we learned a lot because negative studies do deserve to be published. But there was one patient actually in Pittsburgh who was a great responder to that drug. And she could come off all of her asthma. She came off all her asthma meds. Her polyp score went from like a 6 out of 8 to like a 2 out of 8. So maybe we should have published that in our paper too, that we had one patient who responded, but statistically speaking across the board as a group, there was no difference. So I agree with you. The eosinophils are not the end all be all. They are an important potentially marker of disease severity, but it's obviously much more complex than that.
The one thing I'll say with regard to biomarkers, and it's not necessarily a biomarker, but is the role of olfaction in this whole process.
Yes.
And the thing that I've been absolutely stunned with is patients that you start these biologics on, they'll come back after their second injection, or even after their first, and they'll start telling you that their sense of smell is coming back. And you look in their nose, and they've still got polyps filling up the entire cavity. And the first couple times that I ran into this, I really didn't actually believe the patients. But it started dawning on me that the whole hyposmia or anosmia that are associated with polyps, the way that I was classically trained is that it was an obstructive anosmia, that basically the odorants weren't able to get up into the olfactory cleft and stimulate the neurons. But then as this data started coming out with these biologics, there was still a lot of obstruction in the nose, but the patients really objectively were getting their sense of smell back. And so started making us think that it's really an inflammatory process that's causing the smell loss and not an obstruction. And so that's usually the first indication. If the patients are coming back saying that they're getting their sense of smell back, you know that they're going to be responders. If after the second or third injection, they still don't get any smell back, well, either it's, long-term, they're never going to get it back, the polyps may shrink, but chances are those are going to be the patients that are not going to do very well on that biologic. That at least has been my experience.
No, I agree with you. And when we were doing the phase 2 trials of DUPI, when we had no idea that any of this would work, my first patient who had never had surgery, he was a score 8 out of 8. Could not breathe or talk. He had to gasp for air between chewing food because we take for granted that when we eat, we actually breathe through our noses to be able to do that. And after the first injection, and it makes sense because it's a receptor blocker, right? And that's why I was thinking for even Benra, gosh, it would be a rapidly acting medication. But for DUPI, yeah, I agree. The polyps were still there, but the patients were telling me they were smelling again. And I think we still need to understand the mechanistic aspects of that. And so another question is related to smell. Do you think that if a patient is really interested in smell outcomes, and they're, for example, like in an industry like they're perfumier or a sommelier or whatever, and smell is the biggest issue for them, and you had the choice between a biologic and surgery, and the patient, let's say, has had prior surgery before and is worried about preserving smell, what do you think you would say to that patient?
Yeah, no. So in a patient like that basically is dependent on their nose. When I was a fellow, we operated on one of the winemakers out from California. That was his big thing. He needed the nose. I would almost go there. We know that there's a loss of smell with surgery. Okay, especially if we do the draft 3s. That is well documented that there is a decrease in the sense of smell when we do all that drilling along that frontal recess. And even with surgery, because of all the inflammation, you do get decreases, subtle decreases in sense of smell. So in someone like that, I would actually offer them up the biologic before I would do the surgery. If really the driver here is not the nasal obstruction, is not the extra rhinologic symptoms of the sleep, but it's really the sense of smell, I would trial them first on a biologic, see if we can restore their sense of smell, and then avoid the whole surgical conversation.
Yeah. And I think the opposite is true. That's a great point. Patients who are really, you have to really understand, what is driving the disability or the impairment in quality of life. If, for example, the patient's asthma is what is really the driving force for they can't sleep, they're coughing all the time, they're wheezing. And instead of doing something every 2 weeks, perhaps like even benralizumab, which is approved for asthma, which you only have to do every 8 weeks, that might be helpful over something like dupilumab. So I think it's important to realize like what is driving the patient's impairments in their quality of life. Do you have a algorithm of like which biologic you choose for which patient? Because I know our audience is really interested in that question.
So that's why I collaborate with an allergist. So I've got John Basso, who's a phenomenal allergist who does all of our medical management. And then I don't know what his special secret recipe is on who he's deciding which biologic goes to who. And I haven't spent enough time in his clinic to figure it out, but he's got a little bit of a secret sauce that he uses to figure out which patient he's going to use which biologic in first. What we really need is a trial that would do head-to-head comparisons in randomized patients that are basically the same cohort to try to get a better feel as to which patients are going to be more responsive to which biologic.
Yeah, agree. And I think also if you look at comorbidities, like if they have chronic idiopathic urticaria or atopic dermatitis, or that would make sense. If a patient had comorbid atopic dermatitis, of course, dupilumab would be, but I don't really see that a lot with comorbidity, like CRS with NP with atopic dermatitis. I guess if you saw someone with also chronic idiopathic urticaria and they have severe allergic rhinitis or atopic disease, perhaps OMA would be a better choice. And do you worry? My question for you is about eosinophils. Do you worry about the transient eosinophilia that occurs with dupilumab, or have you seen any issues with that?
Yeah, I was going to actually ask you, the only issue I've seen with dupilumab is knee pain in middle-aged women, and I've run into that now 3 times. And it's the only I don't want to call it a complication, but the only side effect that I've noticed, and in 2 out of those 3 women, we stopped the medication. The third one said, "I'll deal with the knees. My nose has never been this clean. I want to stay on it." And so it was knees and hips really that were hurting them. But it was only in women. And I talked to Basso about it, and yeah, it has been now documented in middle-aged women that they can get large joint type of arthritic pain.
Yes. I think the biggest concern I have, and I think for the audience too, is eosinophilic granulomatosis with polyangiitis or unmasking of EGPA. And I know there was a recent paper out by Michael Wechsler that looked at dupilumab and then the eosinophilia and it found to be quite safe. But I think what's really important is to make sure you have the diagnosis. If you suspect a patient might have EGPA, definitely go down that road of the diagnostic criteria of checking the ANCA levels and getting your rheumatologist involved and ensuring, because those patients can have severe consequences from just not being diagnosed. So really important. Let's see if there are any other questions. I know we're coming to time. How long should you continue a biologic? Once a biologic for CRS with NP is started, how long would you continue someone for? Was there a time where after, I know I've talked to some folks that say after a year, I will stop and see how things go. How does it work with, perhaps, even insurance, practical issues for prescribing, or how that works in general?
Yeah. So in my experience, it's for the duration. And that's what I basically told our patients. We don't have, decades worth of data here. But in the patients that they start feeling better, they start basically spanning out the injections, the polyps come back, their symptoms come back. So I don't think that there's right now data out there suggesting that, yeah, if you do this for 2 years or 5 years, you can come off of it. There's nothing out there to suggest that that's going to be the way it's going to run. What we really need to be focusing on is, instead of it being a Q2 week, if they can change the half-life of the monoclonals and maybe go to a monthly or a twice a year type of injection, that would be a lot more easier to swallow than every 2 weeks for the rest of your life. And that's, again, why I look at the age of my patients and I try to decide, do we want to introduce biologics now, or do we really want to try to hold off as long as we can? Because we really don't know what, a decade of, no IL-4 receptor activity might do globally.
Yeah. And I think, some of the omalizumab data, I mean, there was initial concerns, but it is doing something completely different. So, I think it's tempting to try to, say which one is best, but I think we really do need a better understanding of still the amazing work that you have done. The basic science, I think, feeds the clinical research, the translation, which feeds back to the basic science again, and hopefully can be a cycle that is productive in really giving us insights into how the disease, because in general, we really don't understand how some of these biologics work and how they bring back smell. And we have now an inkling that it does decrease inflammation in those critical areas in a systemic way. So I think we're at time now. I wanted to thank Dr. Cohen, and thanks to our audience for the great questions. I would also like to thank Regeneron Pharmaceuticals, Inc. and Sanofi for their support for this important educational activity. A companion patient and caregiver session is available at medlive.com. And please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com and resinsightslive.com to view today's session along with other sessions on demand. Thank you so much for joining us.